Now, it's coming up, I think, close to about 5:25 in Eastern Canada. And I'm delighted to introduce our speakers from across the pond, who, believe it or not, are video calling in live. So Dr. Kevin Smith is President and CEO of the University Health Network, and that's Canada's largest academic health science centre and one of the top 10 hospitals in the world. Kevin has spent his career at the interface of the University and Research Hospital and is passionately committed to the mission of education, research, and clinical care. And during his career, he's overseen the investment of $7 billion in research infrastructure and is a pioneer in advancing integrated care models spanning the continuum of health and social services. I also want to introduce Dr. Andrew Boozary, who's a primary care physician and Executive Director of Population Health and Social Medicine at the University Health Network. Andrew also holds academic appointments at the University of Toronto and at Columbia University. And at UHN, Andrew is working to develop and evaluate and scale new models of healthcare delivery for patients with complex health and social needs. So Kevin and Andrew have got up early to join us and to share a truly innovative social initiative that's made a meaningful difference in the lives of those most in need. So just again to remind you to continue submitting your questions and comments using the Q&A box, and they'll be answered during panel discussion. So Kevin, Andrew, welcome. Thank you for joining us at the crack of dawn. We appreciate it. I know you've got a really interesting story to share with us today, and I'm looking forward to hearing more about it. So the floor is yours.
Thank you so much, Mairead, and very early morning here from Toronto. Pleasure to be with you and pleasure to talk about our journey. I think we're going to put some slides up for you. And our first slide, really looking at pathologies of poverty and our organization's response. I'll tell you a little bit about University Health Network first, perhaps. Next slide, please. As we look at University Health Network, it's a large traditional academic health science center, one of the largest in North America. So we have many hospital campuses. We have many research institutes. We have a school of health sciences embedded within us, which is actually the only one in Canada. The rest are in traditional colleges and or universities. We have a large focus, largest training site for health professional, medical, and allied professional education in North America. So it's a big, complex place, doing a great deal of research, what I'll call traditional biomedical research. So the underlying molecular basis of disease and cancer and anterior rejection and transplantation and the response to stroke, and the list goes on and on and on and on. But as we looked at people who use our service, particularly those in emergency services and issues of chronic disease, we began to realize that much of what we were missing were those folks who we were seeing in our emergency rooms more than anyone else. So they were constantly coming to the emerge. And here is a quick slide on a number of our sites, particularly the Toronto General Hospital and the Toronto Western Hospital, where we have emergency services located. We would see about 250 to 350 people a year, some of them more than once a day. So just think about that. More than once a day, some folks are coming to the same emergency room in the same city, obviously not because they're in a medical emergency, because it's a 24-hour accessible environment that they trusted. And thanks to Andrew and the recruitment of our board, who stepped back and said, we're seeing more poverty. We're seeing a greater divide in Toronto and Canada around the world. We're seeing more people living below the margin, and we're seeing more street people. And we really need to think about how this occurs in a city like Toronto, a wealthy city in one of the richest G7 countries in the world, and how we can better support, look after, and evaluate the kind of services we're offering and the kind of services those individuals need. And they're voting with their feet. Where should we go? They're not going to shelters, as an example. And in talking with Andrew, we'll talk with you more about why. But again, a trusting environment providing care. Next slide, please. Many years ago, and today's day is really about research. And unfortunately, we've all discovered that research and data doesn't mean implementation success. So we're really talking about the social determinants of health, which in Canada were identified some 50 years ago. The landmark document really by Marc Lalonde, then Minister of Health, who identified the perspectives around social determinants and the gradient of income and how income affects all of us and how income affects our health. Income, housing security, food security, childhood trauma, the list goes on. For 50 years or more, we've really known these are fundamental issues to addressing the health of those most at risk in our population. So University Health Network, with their board, made a decision to tackle this very vexing problem and move from research and discussion into an implementation approach. Our first move was to partner with our city, the City of Toronto, led by Mayor John Tory. And the second group we partnered with collectively was the United Way, which I'm not sure if there is a United Way in Ireland, but it really is a single fundraising organization for many, 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 particularly social service organizations and arts organizations across the community. And when we brought the three interests together, the city, the largest academic hospital in the country, and this remarkable fundraising arm, and began asking questions, we looked at focusing on housing and housing insecurity and those who were constantly using health services. We then began to say, should we look at using some of the land which University Health Network has to actually create a housing environment, an experiment with housing that allows physicians and other health providers trusted by those most marginalized in society to prescribe housing. And let me turn it over to my colleague, Dr. Boozary, who will walk you through where we went from there and the exciting journey we've been on and continue to be on. And I want to thank Andrew, who's come to lead this initiative at UHN, and it's getting a lot of attention in Canada and now around the world. Andrew.
Thanks so much, Dr. Smith. Appreciate it that it's this early in the morning. I will return the thanks to you and the board really for the leadership to see through these issues that, as Kevin has mentioned, we've long known in Canada, we've long known in Europe around the social determinants of health. And as Dr. O'Driscoll really spoke to, just how important the other aspects are around the social determinants in terms of where people sleep, eat, the jobs they have, the air they breathe, having a huge and far greater impact in shaping health outcomes than healthcare access alone, as Dr. Smith has mentioned, and just really about what are some of the tangible things we can be doing. I'm going to take a little bit of a walk through in terms of some of the social determinants of health for the audience in terms of where we're at right now. And the reality is, given what we've known for over 50 years, as Dr. Smith has mentioned, it's still a state of where a postal code is a better predictor of health outcomes than genetic code. And as Dr. O'Driscoll was talking about precision medicine, the excitement there about a lot of the research that's happening, we're still in a place where postal code as a proxy for poverty, as Dr. Smith has mentioned, and other systemic barriers and discrimination is a far bigger driver of health outcomes. And this is something where, again, to Dr. Smith's leadership and the board about really saying, are we going to be the university health network or university healthcare network? And if we're going to be the university health network, we have to be thinking broadly about how we partner and better achieve health outcomes through these sort of partnerships. And we'll walk through some of that case study as well, where Dr. Smith will have a chance to also comment on some of the different aspects that we've done around utilization as well. So we're just a quick trip in Canada, because again, this is really lovely at sort of 5:30 in the morning here as we're over the pond in Ireland. And I think it's been nice to get acquainted with each other's health systems a bit more. This is just showing a graph that was published by our colleagues in Alberta in 2018 in our Canadian Medical Association journal. And I think, again, it really shows, Dr. Smith's point about the Lalonde report and saying what we knew in 1974, and just in terms of a little bit of the history, that was just less than 10 years that we passed our Canadian Medicare system about universal health access. And even then, by 1974, with less than 10 years, Minister Lalonde and his team were able to identify a the universal healthcare alone was not going to be enough. That as we look at the quote from the previous slide, we need to pay equal attention to the other social factors like education and housing and employment and jobs. And when you look at this graph in terms of over time, it looks about from 1981 to 2011, a 30-year period, we've seen that there's been an increase in healthcare spending, but not that same rise in some of the social services and social programs, as Dr. Smith had mentioned, being so important. And I think this is one of the elements where, again, we're seeing this utilization of people. We're not seeing that same investment in housing, and people ending up in emergency departments as really their last resort. And I'll just move to the next slide. Great. And so this is just a little bit of a, it was wonderful to be able to connect with the wonderful HRB team a little bit in advance of this conversations about, what's happening in Ireland around, especially the sort of the understanding and action around the health inequalities. Really clear again in the latest report for Healthy Ireland, just how important, furthering Dr. Driscoll's points about the need to be thinking differently in terms of what's happening in the education system, what's happening in terms of other aspects in terms of access to walkability and green space, as well as just, in terms of the employment and income aspects being such large drivers, and this really being so well put together in this latest report for Healthy Ireland, and sort of the vision and roadmap and research being such an important part of thinking about what's working and how this can be integrated. It was the other piece that was interesting as well about Ireland is it sounds like for many of us, in terms of the pandemic, it has really brought to light the issues of the social determinants of health and poverty. And there was a recent report in the Lancet, I believe, in Ireland, just about how clear that's become, and that the authors were hoping that there was this chance to actually catalyze many of the health reforms that you've had underway, especially around Sláinte care with respect to universal healthcare access and more public access to the healthcare system, but hopefully some of the other social determinants of health, as we've talked about as well. And then I think we want to just talk a little bit of a story together in terms of, again, bringing it back to the person in terms of the policy decisions that UHN and the broader implications in the pandemic. This is a photo of a gentleman named Mark, who was experiencing homelessness for many years pre-pandemic. And as Kevin had mentioned, when the pandemic hit, there were people that did not have the privilege of being able to physically distance. So if they're COVID positive or if they're high risk, they're living in shelters. We've all sort of talked about having 6 feet between us. This was not a reality for people early in the pandemic who were surviving homelessness. And UHN, again, really grateful to my colleagues and Kevin's leadership, partnering with the City of Toronto, our community partners, to lift up a hotel site, one of the first of its kind in Canada, to be able to ensure that people who were having COVID symptoms or at risk of COVID could actually stay in these hotel rooms to be able to get their own access to primary care, healthcare, and social services and food security. And, for the first time, have their own bathroom. And so it was really an emotional move. And this is something, again, where we saw a lot of hope through the pandemic, and that things can be done and mobilized in ways that haven't happened before. And how could we start to shift things to these more permanent solutions, which is what we've been seeing with respect to what Kevin has mentioned around some of the bigger action around land and housing, which I'll get to the talk. But this is, again, a moment that I think really on homelessness, most of the city started to see in a way that they just did not see previously, and where we had to work with our community partners really quickly to see something lifted up. Just a snapshot again about how awful COVID-19 has been in exacerbating the inequities in our system. Again, when you think about the privilege of housing, this was a evaluation of research done at the Institute for Clinical Evaluative Sciences that we have here in Toronto, where Kevin is the board chair, that there's been a lot of affiliation with the University Health Network researchers, but showing that 20 times more likely for people to be in hospital, 10 times more likely to be in the ICU, and 5 times more likely to die from COVID if people were experiencing homelessness. And again, that was the reason for why we had to do things for people like Mark really quickly, where there was a chronic lack of affordable and social housing. And again, we see this really inextricable link between homelessness and health. As Kevin has mentioned, again, that seeing people in the emergency department or thinking about ways that we have to deal with this as a real health issue, is that this is the latest data that we had from the city of Toronto around for people who are experiencing chronic homelessness, just how many, most having a quarter, having 3 or more health challenges, and really just how health and housing are really bi-directional in homelessness in terms of what it's imposing on the health system, but most importantly, how it's really siphoning away the human dignity for people in being able to get the sort of health outcomes that people really deserve. And Kevin, I don't know if you want to speak a little bit to the next 2 slides as well, just about some of the utilization, but I'll do the first slide. The next slide is on the emergency department utilization. This one just to show that, again, early in 2019 with our board, when we looked at our own data, this is again speaking to the research, where previous to Kevin's role as CEO, that there was not this deep dive to look at, well, how much are we taking care of or looking at as a safety net or anchor hospital in terms of low-income neighborhoods relying on care at UHN. And we actually saw that over 53% of chronic disease patients were actually living in neighborhoods with less than $35,000 household income. And that's something that, again, was helping to really illuminate the path as to why this needed to be done, and that really large academic hospitals can't shirk this anymore. Kevin, the next slide is for you.
Thanks, Andrew. I can't really see it very well, so remind me what it says, but let me give you a couple of observations. So one, I think cultural evolution of organizations and research-intensive organizations. So particularly at the Toronto General site, but also at the Toronto Western, Toronto Rehab, and all of our sites, there had been a history of being the tertiary provider, the environment where lung and heart transplantation occurs, where the most advanced environments in terms of the sickest people, quaternary care really being the driver, and the emergency room really focusing on people with cancer, people who'd experience or will experience lung transplantation. The list goes on of those very complex issues. And in the ensuing years, the densification of our city saw larger and larger and larger populations living downtown, with greater disparities between them. And so it became obvious, both from a clinical care perspective and a social responsibility perspective, as a teaching hospital, we could no longer be what I'll call ivory tower-ish and focus on those very interesting, but thankfully rare conditions, and really had to embrace looking after those who were in the geography that looked to us for care. So it was, how does one protect and preserve the remarkable Big R research mission, while at the same time opening up and welcoming the environment of much lower interventions, but lower level interventions, with perhaps the most impact of all. And creating that culture in environments that have historically been very Big R quaternary, and moving, almost turning them on their head to look at, but who are the people who are presenting to us and how will we meet their needs, was a research-informed exercise. And as much of what we're talking about today, obviously social responsibility and equity and access are pillars of the Canadian healthcare system. Yet for so long, the ability of this population to remain invisible and frankly lower on the political ladder and event management strategy than they should be. And so this really allowed us to begin a dialogue that said, with providers, help us understand how your program, the multi-organ transplant program, the Peter Monk Cardiac Center, the neurosciences program, the Ajmera Transplant Center, how will you all play a role in looking after this population? And to our delight, the enthusiasm across those tertiary programs was profound. People immediately came to the table and said, we see this population in every one of our programs. Cancer, and particularly lung disease and hepatobiliary cancers. In transplantation, again, the consequences of poverty and lifestyle factors associated with poverty, often associated with mental health and addiction issues, the strengthening of mental health and addiction across all programs really came to the fore. And I think was really encouraging for us when clinicians became research consumers. They also saw the incredible importance of addressing the issues around the social determinants of health for the most vulnerable. And the pandemic only made that more acute. Back to you, Andrew.
Thank you. Wonderful, Kevin. And I also can't see anything at this hour, but I will try to, from memory, that we are seeing this slide showing really the utilization that, I believe that, Kevin and the board really saw in terms of just a small number of people really having high amounts of healthcare utilization that Kevin spoke to earlier, but really just identifying that over, with only 88 patients or clients making up over 7,000 visits. And that really, in terms of, as Kevin has mentioned, this sort of cultural change and recognition and awareness that really we were seeing between Toronto General and the Toronto Western, about half of all shelter residents coming through the emergency department. And again, this is sort of how it was been data driven, but as Kevin has mentioned, really ensuring that there's that program leadership and that recognition for communities that have been marginalized for so long, and just how important this is as a quality of care issue for our organization. And this is again where Kevin has mentioned the initiative, the social medicine initiative that was signed as an MOU in 2019, again, pre-pandemic with United Way in the city of Toronto. And this for, some of the audience is some of the hospital land that's been dedicated to be able to build more supportive housing for people we mentioned who are coming through in and out of the emergency department or the general internal medicine ward or different specialty programs that have been without housing, and that really trying to ensure that this is, again, a quality of care issue about improving health outcomes and ensuring that we are really being there as solid partners around this push of what we've been seeing as a public health crisis of homelessness and the lack of affordable housing in our city. And again, I think, Kevin, if there's anything else here to mention, but there was really the commitment from the board in 2019, and in less than 6 months, the MOU signed, and currently looking to see this happen in 2022.
Yeah, I'll just add a couple quick comments, Andrew. So the board of the organization really committed about $50 million worth of land. And in downtown Toronto, land is scarce, highly valuable, and it was a very, very fundamental statement of our governing body's response and responsibility to this issue. Second, the initial housing, we'll see in 2022, 50 units become available. And very important to define that those units are purpose-built, and thanks to Andrew and the team, with the input of individuals who'd be using them. So again, really focusing on what doesn't work in the shelter system now. And that small R research agenda that allowed us to really look at how do we actually build something that meets the needs of the individuals involved. And so in 2022, thanks to the organizations we mentioned, as well as the investment of the Government of Canada and the Government of Ontario, we look forward to beginning prescribing housing as a medical intervention for those most in need. And obviously, Andrew and the team will be working hard at evaluating that. I should mention that we've also made a commitment with digital health being so important, and knowing that these are individuals with multiple health conditions, to look at ensuring these are the most wired environments one could offer. So if you have congestive heart failure, can we enroll you in our Peter Monk Cardiac Program's congestive heart failure program so that daily we're monitoring your heart failure or your chronic obstructive pulmonary disease or your diabetes. So again, this will be a research laboratory with the full participation and consent of the residents in terms of better management of chronic disease and using the technologies and digital health available to us to experiment on how that could better be delivered at home, at scale, and with better outcomes. Back to you, Andrew.
Wonderful. Thank you, Kevin. And yeah, I think this is just, again, a little bit around to sort of capture, some of the sort of change in how we've been re-envisioning our hospital as anchor institutions in our communities. And I think, again, there's been some terrific work by many of our colleagues at UHN and across the hospital system during the pandemic about the vaccine rollout and partnering as to how to ensure that people were getting access to the vaccine, especially in marginalized communities, but really just about how we cannot be separated from the community, and that these really are, that the walls between community and the hospital are really artificial, and that hospitals are part of communities and are really important players as to how the rest of the social determinants can shape out. And I, again, will have some eyesight challenges, apologies this early in the morning of the graph, but in terms of looking at the sort of top of the image, really seeing Parliament in terms of where many of these decisions are made that have an impact on the social determinants of health, whether it be housing or minimum wage or other policy decisions around education. That all affects the patients and communities we serve, and really starting to see this sort of circle about how we're both working with governments and sort of policy, but especially our communities around how to ensure that we're providing the best quality of care, but really our place in terms of how to ensure as an anchor institution, we're mindful again about how resources are used. And again, I think as Kevin spoke to, the $50 million of land to be dedicated for an issue that, again, we're seeing a real housing crisis in our city and a public health crisis for people surviving homelessness. I'll keep tapping. Next slide, please. Perfect. And I hope I didn't go one too far, but I think that if we look at this piece, and I think this is again where Kevin has really shown so much leadership on the national level, especially around research and innovation, and how much dollars we're spending on research and better understanding, how we're delivering not only, our healthcare, but also the social services. And this was looking at some of the budgets previously, pre to the pandemic, in terms of a $63.5 billion spend. And not as much money, I think many of us would argue, in the healthcare system is going to evaluating what works, what can be delivered better, delivered differently, as Kevin was mentioning, around digital health and different sort of ways of innovating in our system to getting care out to people more seamlessly, more effectively. And this is something, again, we're given the privilege to speak here today around the sort of research agendas and evaluation agendas. This being something that is so important in terms of us, seeing our system evolve and better recognizing the needs of communities and of our patients that many have been neglected, and also ensuring that, this is really about the quality of care. And I think when we look at the same lens, this is again just around sort of healthcare dollars. When we look at the broader piece, I think there's been some really great movements both in Ireland, other parts of Europe, and North America about how are we starting to think about different research ways of measuring what's working when it comes to some social measures, social policy as well. When we're thinking about randomized control trials, the same way we're thinking about evaluating which drugs work and don't work. Should we be thinking the same way about these things when it comes to things, as Kevin has mentioned, around housing, food insecurity, and different programs to ensure that we're really optimizing the equitable delivery of health and social services. But really appreciate the opportunity to be able to have this conversation. And I'll again throw it back to Kevin in terms of the comments, and looking forward to the discussions on the panel and really about how we're trying to best align with where a lot of this leadership has been in terms of a more integrated health and social care system. So thank you.
Thanks a lot, Andrew. Maybe in closing, just a caution. The caution, as we know, is that research doesn't in and of itself change practice. And so as well as doing the great research that DHRB is supporting, it's also incumbent upon all of us to look at how does one take that work and translate it into consumable information that in our countries, our political decision makers and public policy makers see an impediment and an impetus to move forward, the opportunity for a return on investment in terms of political lens, and also cohesion amongst the research community on the right thing to do. I think we're all a bit anxious, at least we're anxious in Canada, that post-COVID or in a world accommodating COVID, with profound amount of debt, more debt than we've seen since the end of the Second World War, will research be, quote unquote, a victim? right? Will we see a retrenchment on research spending? And incumbent on all of us to take projects like these and really talk to funders about the intractable problems, social problems that will not allow our countries to move forward either economically or from a quality of life perspective, and really make sure that decision makers see the impact of research and how it would inform their policy and frankly their platform as they go back to the Irish people to ask for a commitment for their vote. What's their plan with research? What's their plan with evaluation? How will it be implemented? And frankly, how will we align an incentive plan that ensures that results are garnered, not only research in and of itself, which of course is important. So maybe I'll stop there and turn it back to our host, Dr. O'Driscoll, and thank you for the privilege of telling you about our journey so far. We've only just begun, and the future, we'd be delighted to share with you the good, the bad, and the ugly of the future.
Kevin and Andrew, thank you very much indeed for taking the time to share those thoughts with us, and those great examples that you gave, you know, of thinking outside the box when it comes to research, and taking an idea, as the Minister said earlier, that's developed over time and transcends challenges, works across many different areas, and makes a meaningful difference. And I think the points you make about the post-COVID world and making sure that that research continues to be supported and, very importantly, implemented, and that we measure what works. They're really, really important points. So we will pick some of those up, I think, in the panel discussion afterwards. And I know you're going to be staying with us to join us for that discussion.